Welcome to the final video in this series looking at the posterior aspect of the anterior abdominal wall, the umbilical folds, hernias, and the deep inguinal ring. Let's go. The very last thing we are going to do is look at this from a different view. We're going to take our anterior abdominal wall off of our body. So I grab my anterior abdominal wall, I cut it off, and I grab it, and I fold it down, and I look at the back. Because there's some structures on the back that we need to address. Because this is a strange view, I want to talk about it. So this is where I want to start. We start with what I just described, taking my own anterior abdominal wall off, all the muscles, all the layers, and folding it down. So what we're really doing is we're taking, if this is the head, neck, chest, and then this would be our costal cartilage and our costal margin, and this is down where our butt and our genitals are. We have a pelvis down here somewhere. We are taking all of this and bringing it forwards so that it kind of is like a flap like this, so we can look from the internal aspect. So we took that off and now it's folded down so we can see our abdominal contents at that point. So our liver's probably over here, lots of guts and stuff that's covered and you can't really tell what stuff is. Some pelvic structures maybe poking up, but you can look down into the pelvis and we can really see the structures that exist on the back side, the posterior aspect of our anterior abdominal wall. And I'm just looking at from the back. So as if we're inside the body looking out. And this is what we will see. In lab, it is folded down usually or off to the side. So it's a little bit disorienting. But I just want to make clear what we're actually looking at. And to get this off like that, you actually have to cut some structures on your liver. And that's because when you were a fetus, your umbilical vein, which came through the umbilical cord, went to the liver through a structure we now call the round ligament of the liver. So I'm going to talk about that a little bit. So to get this all the way off, like I'm showing you in this image, you actually have to cut the round ligament of your liver, and you have to cut a little bit of what we call the falciform ligament because it connects to the anterior abdominal wall from the inside. So after you cut those structures, which you've definitely done in lab, you can fold this down. So I just wanted to make that clear before I moved on to this picture. Okay, so I know this is a really weird view. Imagine you are hovering above the cadaver as if you're levitating over top of it, and your liver's here, your stomach's over here. So you have your right side, left side, all of your abdominal contents, the colon mostly, the intestines here, small intestines, all of your abdominal spleen, liver, all that stuff is here. And now you've taken the anterior abdominal wall and you pushed it back over the legs. Head's down this way, legs are up that way. And I know it's a strange view, but it's the best view for the posterior aspect of your anterior abdominal wall. And what we see here is some folds on the backside of our anterior abdominal wall. And these brown lines, which I will shade in eventually, are my rectus abdominis from the backside. They're kind of on there. I don't even know the term for that. They're kind of hard to see on purpose because I want to remind us that back here, there is a line at which the rectus abdominis becomes much more visible from the internal aspect, and that would be called the arcuate line. So the arcuate line is visible from the internal aspect. It will just look like a little fold where all of a sudden it's kind of hard to see anything from the backside up here. Like I don't just see my rectus abdominis muscle, but below a certain point where the arcuate line exists and my tendons, my aponeuroses of my internal oblique and my transverse abdominis are suddenly not behind the rectus abdominis, but are only in front, then I have much easier time seeing my rectus abdominis from the internal view, looking out, because there's less tendons blocking my view. Because now they're in front of the rectus abdominis, not behind it. And so I'm really just seeing transversalis fascia and that parietal peritoneum. I'm pulling up both of these views so that we can look at a new concept. So the internal, like peritoneal cavity, we've seen this picture before in the last video. This is where it is, right? The abdominal cavity is in here. Our parietal peritoneum is the most internal layer, then our extraperitoneal fat, then our transversalis fascia, then all of our muscles and their aponeuroses. We've seen this stuff before, so I'm not going to go through everything all over again. But I am going to cover and fix our picture over there so we really understand it, what's going on here, because I've added in some stuff that occurs in between the transversalis fascia and the parietal peritoneum, sort of in that extraperitoneal fat. So there are some structures on both sides, so I've drawn one side and the middle, that we're going to examine in that posterior aspect view, but I wanted to show you really where they are and what they're called. So I just said we're going to look at some folds. These are the folds. So I first want to define what is a fold. A fold is one of these structures on the posterior aspect of the anterior abdominal wall. It is a structure or structures underneath parietal peritoneum. And technically that's in the extraperitoneal fat. So here's my extraperitoneal fat kind of supporting the existence of this structure and parietal peritoneum. I'm exaggerating the thickness of those layers. Behind that, so deep to that, because we've reversed where we are now inside looking out towards the outside. That means our transversalis fascia is actually this layer now. So this is what a fold is. It's just a structure covered with parietal peritoneum that's kind of making a bump because there's something there. In other places, it would be more flat like this. Where we see these folds, it's because there's a structure under there or in between there, and it makes a little bump. That's it. And we typically call them umbilical folds because these two that we'll discuss first on the other view are going to go towards the umbilicus. So we're going to cover 3 types of folds: a median, 2 medials, and 2 lateral folds. The other thing I want to do with this is make this picture more accurate to match our other pictures. I left out extraperitoneal fat because it's really not that big of a deal, but I want to make sure you have an accurate picture. So we have our transversalis fascia, we would have a extraperitoneal fat layer, and then we would have our parietal peritoneum. And now we know that if there are structures in the posterior aspect of the anterior abdominal wall, they're going to be in that extraperitoneal fat between those 2 layers. And I will say this right now, before we move any further forward, that's in most textbooks, not all textbooks. Some resources tell you that these structures are actually underneath your transversalis fascia. I'll show you the difference. So most textbooks are going to explain this like so. Structure, 2 structures inside of that extraperitoneal fat, and then they make these sort of bumps on the back side. All right, so that's most textbooks show these structures that we're going to talk about that are on the posterior aspect as in between those 2 layers, but some show them as being behind, more superficial to the transversalis fascia. So I don't know which is correct. This is the one you see most commonly. This is the one that makes most sense to me. This is the one I would go with, but I will never lie to you about what I do and do not know. I do not know who is right about that. I also don't think it really matters, but I'm pretty sure it's this. Most of these structures that we're looking at here are remnants from embryology that no longer function, but are still sort of there. But we're going to cover what's in each one of these folds and what these folds are called. Now we have 5 folds in total. We have 1 in the middle, and then we got 2 and 2. So 1 most middle, when we say most middle in anatomy, we call that median. Median means most middle. So our median fold is 1 singular fold in the middle that goes up to the umbilicus. Just for reference points, we saw this is the umbilicus up here. It's got this little tail that I gave it, which is to represent the connection to the round ligament of the liver, because we had to cut it. So here's the round ligament of the liver down here. The other name for round ligament of the liver is ligamentum teres. So I'll write that one down here. This is the same thing. Ligamentum teres, round ligament of the liver, same thing. What's most important is what was that structure? It used to be the umbilical vein. The umbilical vein. This is a remnant of the umbilical vein. No longer functioning. We don't need blood from mom. We live on our own now, and so we have a remnant structure, the round ligament of the liver, ligamentum teres, used to be the umbilical vein. Not a fold, but just a structure we need to know. So the median fold, back to the median fold. The median fold is here, right in the middle, goes straight up to the umbilicus, the belly button from the back side. It is coming from a structure, an adult structure. It's going to be hard to see that adult structure at this point in your dissection if you haven't hemisected and done pelvis, where you split the pelvis in half so you can actually see the structures. So you're just seeing the top of a pelvic structure, and that pelvic structure is your urinary bladder. UB for urinary bladder. So this structure that is now a fold is another remnant from development. And this structure comes from the apex of your urinary bladder. So if I were to hemisect someone, I'll put it over here. If I were to hemisect someone's pelvis, they'd have a sacrum and a pubic symphysis and a pelvic floor and all that jazz. Really close to the pubic symphysis, they would have this structure that is their urinary bladder. And then it has a urethra. This is where we store urine temporarily, right? So what you're seeing from this view is just the top of that urinary bladder. And when you were a fetus, you had a connection, open connection from your apex of the urinary bladder, the point, the tip, up to the umbilicus that used to open into the amniotic sac. So like literally our amniotic sac, that fluid sac that we used to live in and drink out of. Yep, hopefully you know where this is going. We used to pee out of our umbilicus into that sac and then drink that urine because we're gross. I don't know. And that is the structure that we're talking about. This is the urachus, the connection of our urinary bladder to the umbilicus. We used to pee out of our umbilicus, out of our belly button, into a sac of fluid, and then we drink that fluid and do it all over again. We're very sustainable, if you will. When you become an adult, this structure shuts. And it should. It doesn't always, but it should shut and become a ligament. So as an adult, we just have a closed bladder and a ligament that connects to our umbilicus, which now we don't pee out of our belly button. That would be alarming as an adult, maybe. And we also don't have an amniotic sac. So this is what we're looking at in that median fold. This structure is called the urachal ligament. So inside of our median fold, also known as our median umbilical fold, inside of our median umbilical fold is the urachus or the urachal ligament. So it's the urachus or urachal ligament underneath parietal peritoneum. That is what the median umbilical fold is. When you are getting tested on this material, they will ask for both. You need to know both. Okay. There's one median umbilical fold. It kind of makes sense. We only have one connection of our bladder to the middle, to the umbilicus. The next folds, there's two of them now, bilateral on both sides. I'm gonna highlight in red. There's a really obvious reason I'm doing that, but I want you to watch something. They go into the pelvis. So the next bilateral folds, they're not in the most middle, but they're pretty close to it relative. We call those medial folds. So we got two medial folds, and our medial folds contain a structure. And this is a cool one because I love pelvis. So I have a special place in my heart for this structure. Without getting into details, you have arteries in your pelvis. And they go all over the place and they supply your organs. One of those arteries gives blood supply to the top of your bladder. So functional artery up to this point. You don't need to know the name of it yet. You will later. These are just pelvic arteries. One of these arteries gives off a superior urinary bladder artery and then becomes a ligament and runs up to the umbilicus from both sides. Because you have pelvic arteries on both sides, bilaterally. So you have this very unique structure that is an artery giving blood to the top of the bladder, but then turns into a ligament and goes up to the umbilicus, like we can see here in the medial fold. So what that is the obliterated, because it doesn't function anymore. On both sides, we have obliterated umbilical arteries that can be found in our medial folds. They are ligamentous now. There is no blood coming up here because we don't exchange with mom anymore, and therefore we have an obliterated artery, a non-functional artery. It is partial functional in the pelvis, and then it is non-functional because we don't need it anymore. So that's what's in here, is the remnant of our umbilical artery, which we call obliterated. So obliterated umbilical artery is found in the medial fold. Urachus found in the median fold. Now what's left? Lateral fold. Lateral folds are the only folds that do not contain a remnant structure from development. This fold is actually containing something functional that we use as an adult, and it's going to look something like this. It's actually two structures in this fold. So we can see an artery and a vein that exist in our lateral fold. And we have two very functional structures inside of our lateral fold, or underneath parietal peritoneum. These structures are our inferior epigastric artery and vein. So our lateral fold contains the inferior epigastric artery and vein on both sides. Inferior, because remember, we're at the bottom of our anterior abdomen. We're going up. And the inferior epigastric arteries and veins will kind of go on the back side of this muscle we can see here, sort of, that is our rectus abdominis muscle. We'll supply it. And the other muscles as it goes up to meet and anastomose with the superior epigastric artery and vein that you know and love. And I'm going to show you why with a little person. So there's my thorax, costal cartilage margin. Here's my abdomen. There's my umbilicus. And then we got legs, all that jazz. No arms. We don't need them right now. You guys learned about an artery that runs down your thorax on either side, on the back side of the thoracic wall. That was called your internal thoracic artery. That artery gave off two arteries when it terminated. One of them was called the superior epigastric. The other was your musculophrenic. So superior epigastrics come down. This is our inferior epigastrics coming up to meet with and anastomose with our superior epigastrics. So here's inferior and superior epigastrics. And those are going to anastomose together. Epi means above, gastrics referring to all of your GI organs. Above the GI organs. Gastric really refers to the stomach, but whatever. Now we're going to uber complete this picture so that you know your folds, but you're going to be an expert at finding your deep inguinal ring, and you're going to be an expert at hernias after this. So we know that it contains our inferior epigastrics. Our inferior epigastrics, and I'm going to draw it in a little more clearly. Some of you are probably going to dissect them out, and then you'll see this a little more clearly, is my rectus abdominis muscle on both sides. Because people are going to talk to you about a space called Hesselbeck's triangle, and they're going to use it as a way to discuss hernias. And I'm going to bring up to you an easier way, potentially, to do this. So Hesselbeck's triangle, I'm going to teach it to you, but then I'm also going to teach you some other stuff. Hesselbeck's triangle is a triangle that exists between these boundaries. So I'm going to give you its boundaries, and then we'll learn more about it. Our inguinal ligament, you can imagine, is about here. The sides, the lateral aspect of my rectus abdominis muscle, and then the lateral fold, or inferior epigastric vessels, make up this triangle. So you can see how a triangle is within those three structures. Inguinal ligament, which you won't really be able to see. The side, or lateral aspect of your rectus abdominis muscle, and the inferior epigastric vessel make up this triangle called Hesselbeck's triangle, also known as the inguinal triangle. And this triangle is where we tend to have direct hernias. That's really what it is all about. They also say that if you are lateral to Hesselbeck's triangle, you are more likely to have an indirect hernia. And I would like to discuss the difference. So first things first, we really need to understand what an indirect hernia is and a direct hernia is, because the terminology is a little silly. So an indirect hernia versus a direct hernia. Now, indirect hernias happen lateral to the epigastrics, or the Hesselbeck's triangle. So an indirect hernia, ID, is going to happen lateral. Doesn't matter which side. A direct hernia will more likely happen medially, in that Hesselbeck's triangle specifically. Why? Well, because an indirect hernia is a hernia that goes through the entire inguinal canal. So that means it has to go through the deep inguinal ring, and it has to come out the superficial inguinal ring. Whereas a direct hernia does not go through the deep inguinal ring, but instead handles a much more direct route of getting out to the superficial inguinal ring and just punches through the abdominal wall to get there. So a hernia, to backtrack, a hernia is when you have structures or fluid from the abdomen that are put under pressure and sort of squeeze out in a different area it's not supposed to be. Typically that happens where we've had something pass through or used to exist. So another example of this would be you can herniate through your umbilicus. There's a lot of remnant structures that used to be open, used to be patent, that's the word for open, that you can, under higher pressure, force back open, essentially. One of those structures is also the inguinal canal, because there's stuff that passed through it, and sometimes you have it open and it's patent, and that's a problem, usually, because you're more likely to hernia into an open tunnel that already exists. So when we are put under high pressure abdominally, peritoneally, we are going to force sometimes abdominal organs, like the intestines or the colon, or just fluid through the anterior abdominal wall, and both types of hernias, direct and indirect, will actually come out the superficial inguinal ring. It's just, how did they get there? Did they take the entire canal, or did they just go through the wall? So let me draw both scenarios for you. Here's our inguinal canal twice. And here's the difference between a direct and an indirect hernia. The superficial inguinal ring is more medial. The deep inguinal ring is more lateral. This is my deep inguinal ring from the inside. Notice how it is lateral to my inferior epigastrix. So let me put in inferior epigastrix. Here's my inferior epigastrix. So it's always lateral. This is like the same side. I should have done two different sides, but I did the same side. So hopefully we can see that. So what's the difference between a direct and an indirect hernia? Well, let's do indirect first. An indirect hernia. Indirect takes the longest path. That's how I would describe it. An indirect hernia will go in through the deep inguinal ring, through the entire tunnel, and out the superficial inguinal ring, and bulge out. That's really what's happening, is a bulge. You could think of a piece of intestine going through and sticking out because high pressure forced it in there, or fluid. But you'd see a bulge right where that superficial inguinal ring is. And an indirect hernia goes through the whole canal. A direct hernia ain't got time for that canal. A direct hernia typically occurs medial in Hesselbeck's triangle, so it's in between the rectus abdominis over here. That might help prevent herniation a little bit, unless the abs are weak. And this inferior epigastric artery, it's going to come out in between those two structures, punch its way through the wall into the inguinal canal somewhere midway, and come out of the superficial inguinal ring. So direct just punches through the wall, typically in that triangle that we just discussed, does not enter through the deep inguinal ring. Ain't got time for that. It's just got to get out. So it's like, I'm out! Bust through the wall, out of my superficial inguinal ring. Indirect takes the entire canal. That's really the largest difference between the two. So now that we understand the difference between direct and indirect hernias, one thing I want you to be able to do is identify the deep inguinal ring. I kind of showed this to you earlier when we were talking about the development stuff, but I'm going to solidify it hopefully for you right now. The deep inguinal ring is hard to find. And once again, I'm going to split this person down the middle, and we are going to have ovaries on this side, testicles on this side. So ovaries are internal. So we might see an ovary like here, and a little fallopian tube over here, little arm, little uterus, which would be on top of the urinary bladder actually. There may not be a uterus in there. Lots of people have had hysterectomies by the time they get to the lab, so you may not see a lot of uteri. However, you'll probably see some uterine tubes and ovaries, but not always. If they're there, check them out. If they're not, you'll have to go to a different body. And on the other side, we don't have a uterus. Instead, we might have a little seminal vesicle and this structure, which is a tube coming off and headed for the deep inguinal ring. Some of you may know what that structure is. That is the vas deferens that carries sperm into behind the urinary bladder, because in people with testicles, the backside of the urinary bladder which sits on top of the prostate gland. This is my prostate gland. Urinary bladder, actually its urethra goes through here, and then it goes into the penis, which I'm not going to draw on the board. Urinary bladder sits right on top of the prostate gland, and next to the prostate gland are these two sort of weird looking butterfly wing structures that are glands called seminal vesicle glands. And coming in from outside is that vas deferens. So the vas deferens come in from both sides, and everybody is actually going to empty their contents through what we call the ejaculatory ducts into the prostate to then enter into the male urethra. So vas deferens has to get to the back side of the urinary bladder. That's where it's headed. It's going to come in and down immediately. It's going to dive. So you can see it and you can use it to find your deep inguinal ring. The other things you're going to see are those arteries and gonadal arteries and veins I mentioned earlier. They're going to be coming from up here, and you'll have to dissect through your organs first, but you will see an artery coming this way, and you'll see a vein running with it towards that deep inguinal ring. And this is the only way I look for the inguinal ring. I find several things, right? You always got to prove to yourself what you're looking at. I find my inferior epigastric vessels. I look lateral to those. And then I look for my vas deferens, and I look for my gonadal, like some random artery and vein headed for the same spot as my vas deferens. That tells me that's my deep inguinal ring, which doesn't look like much, to be honest. Just looks like a place that all these things are going. If, however, I have ovaries, I'm dealing with a slightly different scenario. We talked about it earlier. The gonadal vessels will go straight to the ovary, not to the deep inguinal ring. So they can't be my landmark. That's unfortunate. Instead, I will use the other landmark we discussed earlier, which was the round ligament of the uterus. So the round ligament of the uterus is that remnant gubernaculum will come off of the uterus and beeline for that deep inguinal ring. Harder to find for sure. You can still use lateral to my inferior epigastrics. Look for a structure that is kind of thick, that is headed from down here to out there. Honestly, the round ligament of the uterus and the vas deferens look incredibly similar in the way that they kind of arc to go out. So look for a structure that arcs to go out, lateral to your inferior epigastrics, and you can find that deep inguinal ring any day of the week.
And that's the end of our anterior abdominal wall series. Thanks for watching. I really hope it helps.